Good morning. It's a pleasure to be here and to be a part of this event. I want to congratulate Ronnie Goldstein and David Garber and the Salamas, Maurice, Henry, and Eddie for organizing and putting together an exceptional occasion for all of us to reevaluate our cherished beliefs and to perhaps have a fresh thought process about some of the treatment regimes that we encounter. Because time is limited, I'm going to try to make the most of it, but we're going to talk about clinical decision making. If we want to consider when to save teeth in adults, we have to think about prognosis. I don't know about your patients, but my patients ask the same questions, I'm sure, as in all 30 countries that are represented. How much are you going to hurt me? How many visits will I have? How long is this going to take? What will my appearance be? Some patients even know the word aesthetics by now. And finally, if I do everything you say, how long will the result last? And this is a pretty good question. We can tell them that it probably will last longer than their 1980 Buick or whatever automobile they drive, but still, it's a realistic question. As we think about periodontal disease and the loss of teeth to periodontal disease, which is, I don't want to say an epidemic, but is a major factor in decision making, we are alarmed by the results of our studies. If we take all the exercises that we perform, the result is ineffective for teeth that have advanced disease. As a periodontist, I usually don't get to see patients that have a normal dentition, maybe the children of long-time patients to try to prevent their problems. Diagnostics are important, and today with implant dentistry, it's routine to use CT scans to measure the way things are. It's very difficult to have hard rules, or as the organized dentistry would like to have evidence-based dentistry. It's a question if that even exists. But let's look at two first bicuspids. One has a furcation problem. I have to adjust all this. I guess this has a furcation problem and has small roots. And if you just extract this tooth, there's enough bone that if you have any hand-eye coordination, it will be easy to place a dental implant. If this tooth has no problem, but if it did have a problem, then we would get into an osteogenic procedure because we wouldn't have enough bone to place a dental implant. And this is why we can't say there's a rule for first bicuspids. The great part about what we do is we have the challenge of each patient being a significant one of a kind. And of course, they come in bunches. But there's plenty of opportunity for us to maintain our interest in what we're doing. Also, just having an advanced defect, as you can see on the mesial surface with the yellow arrows, doesn't mean you're going to lose the tooth. This is a patient that was as poor as a church mouse and could afford nothing. But we cleaned her teeth, and she paid $20 a cleaning and paid $5 a month till we got through that, and then there would be another cleaning, and she was very loyal about keeping her mouth clean. And here you see that there are two first bicuspids with deep osseous lesions that really did not deteriorate over a very long period of time. 37 years is almost 2 generations of observation. I consider that an outrider. That's not what we expect when we see defects like this. Can we regenerate? Can we treat these effectively? Well, this is 1988, so it was before we had many of the materials we have today. But you can see that there's a very big problem on a non-restored first bicuspid that's totally stable. And my rule of thumb for treating patients is, what would I do if this was my dentition? And in my dentition, I'd say, let's take a shot at saving this. This tooth was single-rooted, so it didn't have a furcation between the two roots. This is reopening this, and the radiographic change, you can see the arrows, and reopening this after a year after regenerative treatment. So this dentition was able to remain intact. Let me say from the beginning, my first dental implant was 1966. And I have no idea what total number of osseointegrated implants I've placed over the last 25 or 30 years. But it doesn't mean that an implant is the only successful therapy. In my practice and in my life, the two major advances have been osseointegration and regeneration of structure, periodontal regeneration or regeneration for purposes of implant placement. We also, at times, can be guilty of overestimating a patient's level of health. This patient in 1989 refused any treatment because it was too complicated for her, and she disappeared. She was referred back again 5 years later. You can see that there's terrible destruction, but there's no way that you could look at the 1989 radiographs and predict this for a patient with no medical history, taking no medications, not even an aspirin. So what I'm trying to say is that we have to realize that we don't have all the answers, and we're not existing in a hardline evidence-based diagnostic world with periodontal disease. And we have to, our major goal with any of the therapies we produce is to create an environment that the patient and the hygienist can keep clean. My topic this morning is periodontally compromised patients, and immediately that indicates these people are susceptible to disease. When a 31-year-old attractive female presents with a radiograph like this, I drew a red line, and I told the patient, if I'm the luckiest periodontist in the world, that's the best I can do with regeneration, because I have to ask myself, where will the progenitor cells come from, and where will the vascularity come from? And that's going to be dictated by where the bone is. So that's the best I could do. And if I did that, you're going to have black triangles. She had a big display, and with a lot of conversation, we decided we'll remove those two teeth, rebuild the bone, and place 2 dental implants. And there she is in 1999, and there she is in 2006, and there she is in 2010. It's remarkable that somebody that could suffer that degree of periodontal disease with the same bone and same gingiva holds stable with the implants. And we've debated this since 1995 when Bert Langer and I published a paper of 300 plus implants in people that we failed with periodontally. So there's a balance, and this is what makes it so interesting. It's making the right decision for each problem. When we think about what's the prognosis of an individual tooth, well, can you get rid of the pocket? Because the pocket, if it measures 5 millimeters or more, has periodontal pathogens, so-called red complex bacteria, and this is going to result in additional loss of bone. That's predictable. Who knows what's going to happen in a patient's life? If you take all the people in your life and subtract those that are disenchanted with their occupation, or the reverse, the occupation is disenchanted with them, 50% of our population of marriages ends in divorce. And how many of you in this room have teenage children? I don't need to say no more. So any patient who's the champion of oral hygiene can become the chump very quickly when an adverse event occurs. That people want to know, how long is this going to last and what's it going to look like? So, first, can we save teeth that are terrible? This is a dentition in 1968. Finances were somewhat limited because her children were in private prep schools, and I did surgery. First, I splinted her teeth because her chief complaint was mobility. Then I went to the edentulous maxilla and used autogenous bone to rebuild everywhere that I could. Here's 20 years later, she still has the same 10 teeth. Then they really were beginning to look terrible because of all the efforts at hygiene and her meticulous home care, and I suggested maybe it was time for her to see her dentist and have the teeth restored. Well, that was 1994, and this is 2001, and this is 2007, And here we are at 2010. This is 42 years later. She still has 9 of the 10 teeth. And the one tooth that failed was the central incisor that began with inadequate endodontic treatment. It's possible to keep people with teeth. And as impressed as I am with implants and as dedicated to our researches towards implants and my lecturing towards implants, we have a decision to make with individual teeth and with patients. If we need to figure out how to treat adult patients, make their mouth clean, if the teeth are really loose, stabilize them. If they complain they can't bite because the teeth are loose, get rid of the pockets and have a maintenance system. And you know what? This works just the same for implant success. Our incidence of peri-implantitis is minimal compared to what I encounter when I'm in Europe lecturing. Let's look at a tooth that we could consider to be hopeless. It's a young man. I don't know, the tooth's vital. I don't know why this has happened. He's referred for me to remove the tooth, do site development, and place an implant. And I thought, because he hasn't been out of university very long, I better explain how expensive this is going to be. And his complexion was about as white as this cup by the time I finished. And I said, if you want, we're doing some research with a new product, and we have permission to do it, and it won't cost you anything if you just sign on the dotted line. And when he saw that it was in big, bold, black letters, he understood and believed me. So this was treated with an allograft and platelet-derived growth factor. It's the only time I ever used a barrier membrane with this growth factor, since this was just trying different things. But I haven't used a barrier membrane for periodontal regeneration in a long time. Now, here is this area when it was 13 millimeters deep. Notice that the tissue is pink and it's not bleeding. So pink, non-bleeding tissue does not mean that we have health. And this is a very good thing to think about before you place dental implants. First, we should eliminate the periodontal disease. Here it is after treatment when it measures 3 millimeters in 11 months. That's the original radiograph and the treated radiograph. This is the original defect, and this is reopening at 11 months. What's happened is I've created an environment that the patient and the hygienist can maintain. And that has to be the ultimate goal of what we do. None of us have ever cured anybody. So once we showed that we could do this in different, did it with human histology and whatever, then it was necessary to answer the question, how predictable is this kind of treatment? So we did a multi-center study of 180 patients. This is the largest periodontal regeneration study that ever has been attempted. But we needed this to get regulatory approval from the FDA. Notice, as bad as this tooth is, when the probe's in place, the tissue is very pink, the mouth is very clean, and there's no bleeding. That does not mean periodontal health, as you can see radiographically and clinically. This is treated with the product GEM 21. It's sutured. Look at the healing in 3 days, because this also promotes excellent soft tissue healing. Here's the original defect, and here's the result at 12 months. A tooth that is non-treatable, mandibular cuspid, a diastema that we never did anything to treat. It just moved back together after the disease was taken care of. And you might say, well, okay, 12 months is a short period of time. So here's 3 years. And here's 6 years. And here's 10 years later. We're just now publishing the 3-year results, so we're a little behind in publishing. But what we can do today is so different than what we did before, and yet it is so difficult with health professionals to change the paradigm of approach to treatment. As we look at this maxillary lateral incisor and consider the possibility of placing an implant because there's a lot of bone, My advice is this is a terrible place to place a single implant because the patient wants an aesthetic result. The other wasn't meant to come up, so just stay with this one tooth for the moment. If you place an implant here, the implant abutment junction is going to either evolve into a crown that will be an inch long, not millimeters, and ugly with black triangles, or we're going to bring soft tissue up to try to cover it because we really have no way of regaining periodontal attachment vertically from a flat bone defect. So putting an implant here has a good chance to meet the same fate as the picture now to the far end there. A colleague brought this case to me and said he didn't understand why there's a problem, but every time antibiotics are stopped, the fistulae reappear. I promised I would never tell his name. Well, as you look at this and you begin measuring, that you shouldn't do. As you look at where the implant abutment junction is, and you look at the length of the pontic, and you see how far subgingival and subbone these implants are, there's no doubt in a periodontally susceptible patient, and if you look at the lateral incisor, this is a periodontally susceptible patient. There's no question that this is a big mistake to bury these and just bring soft tissue and think that you're going to maintain this long term. Also, consider the fact that there's no history that periodontally compromised patients stay under significant maintenance care greater than 32%. It's very difficult to keep these people because of how the society moves around. Now, sometimes it should be an easy decision. There's the molars are missing. There's a terrible second bicuspid. The foramen's at the apex. And the question is, do you take the tooth out and put an implant? On the other hand, it's a defect that I'm sure I can make great advancement with regeneration. But in this instance, it seemed better to just put 2 implants distal to it and have a cantilever. Now, you can argue that that's a bad idea and cantilevers fail, but we'll be able to track this for 20 years and nothing's happened. I could have removed the tooth, rebuilt the bone, and placed a 3rd implant, but it didn't seem to be necessary. And in 1992, I had a hard time defending this, but by 2010, 20 years later, it's become very easy to defend this treatment. So extracting the tooth was the right thing to do in this instance. Little furcations grow up to be big furcations. And Class 2, the management of Class 2 furcations is a fantastic event in a periodontal practice. And this is what happens, and when it gets to a certain point where you can't maintain it any longer, we replace it with an implant. Part of it is, of course, reconstructing the small amount of bone loss at the time the extraction occurs. But how about when we see teeth like this? The culprit is the partial denture. I don't remember exactly how it happened, but as I was holding the partial denture in my hand with a glove, it broke in half. And there was no way of putting it back. You can see that the patient has a terrible problem, but she does not have leukemia. Her soft tissues are nice and pink when the partial denture is not touching them. The patient had to have a full maxillary fixed prosthesis. And at the time she was treated, we were not involved with implants, to the degree we are today anyway. This is accomplishing the first step, making a dirty mouth with mobile teeth clean with stable teeth by splinting. The splinting was done in this fashion because financially she couldn't do maxilla and mandible at the same time. But at this time, even though the tissue is pink, there's so little tissue there that it's not enough to really create a seal. Much effort is made on doing gingival grafts in the buccal. And this is nice to make people feel good about their appearance. But where is calculus? Every patient that sits down in your hygienist's chair, where is the calculus? It's on the lingual, the lower anterior teeth. and we need protection there, especially in a case like this where we must preserve these teeth. Well, here she is when it was finished in 1973, and here she is in 2003 after she got over the sticker shock of the maxilla and was ready for the mandible. And as we look at what appeared to be terrible bone loss in 1973, over 30 years, she's done very well. History, 42 years, she died in April of 2010. This is an old subperiosteal implant. So just the wonderful thing of having osseointegration and not having to do things like this anymore is fantastic. Therefore, when this patient presents and we look at the radiographic survey, it's obvious this patient would be much better off with dental implants. And the predictability for periodontally compromised people is very strong. But sometimes we have a deep defect and we'd like to keep the tooth because there's no embrasures and there's 100% overbite and she can't floss properly because she can't fit her fingers in her mouth. And we look at a defect like this and we say, now we have to make a decision. If we put an implant in here, I don't know really how much that's going to solve because if we start crowning teeth, there's no embrasures and she can't take care of them without crowns. So the thought was, let's do periodontal regeneration. And this was 1988 also. And you can see where the structures have regenerated. When she fractured her first bicuspid, it was a good opportunity to extend the flap and take a photograph. So part of keeping track and records is having information. And there's her 1989 radiograph and her 1999, so a 10-year result. On the other hand, this young lady had a terrible automobile accident. I could visualize the apex of the central incisor. You can see where her mandible was fractured. Removed both teeth. One of my partners, Roger Wise, is what I call a porthodontist. He's a periodontist and an orthodontist. And without doing any soft tissue grafting, just managing the soft tissues properly, we're able to place an implant. Fortunately, she broke a mandibular incisor. Her mandibular incisor is not maxillary. But you would never know that that happened. This was her 10-year anniversary. Simple solution, but you have to think through what you might do. And you could see how poor the soft tissues were and how routine it looks in the end. Now, in the maxilla, this happens too. 22 years old, motor scooter accident, fractures of teeth, has 3-4 different consultations, mixed direction, parents are concerned. Endodontics was done. The question is, are there more fractures? Should we put 2 implants, 4 implants? Where to put implants? And the thought was, why don't we just open the tissue and see if there are any other fractures that we're missing? And if we can get to a point of crown lengthening, maybe it'll work out very nicely. Now there's enough tooth structure. Superb prosthodontist. Everything fits beautifully, very cognizant of patient care. You can see where the tooth preparations end, just a millimeter below the gingiva. Fantastic result, keeping the teeth. But he's 22 years old and nice big roots with a lot of bone. Now, another patient who's the role model for osteoporosis. I've been a patient a long time. She has a bull mastiff for a dog. She was walking him. It saw a squirrel. It flipped her around and her face right into a telephone pole. As she was removed from the hospital, she came back, and these were her radiographs. A terrible situation. Teeth are broken. Bone is lost. It's periapical defects. There comes a time when you have to say, these teeth should not be saved. But she's 77 years old, and she's not 22, and she doesn't have long, big roots. So we have to take these things into account to make the decisions. And I placed 4 implants immediately with her, and it works out. Same with root sectioning. Here's 25 years later with a short span. It looks great. Another case where there's obvious class 3 FERCA, class 2 on the second molar, big roots, need for all new restorative dentistry. I would treat this case the same way today, 24 years. But this case I would treat differently because I have very little to work with here. And there was an endodontic perforation of the mesial root, and that left me a distal root with 3 ponics. And it took a very special dentist to make this work for 27 years. Unfortunately, he's passed away now, Howard Scurrow, but he did an unbelievable job with it. Sometimes you just have a fractured tooth. You see the gutta percha cone to the yellow arrow. You can see the 2 apico restorations distal to the implants. These are 20 years later. But keeping track of these people is an interesting thing. Now, I know I'm running out of time, so I'm going to try to go quickly, but here's a tooth that every one of us in this room would extract if she hadn't signed an informed consent to let us take this tooth out for a histologic examination. So a lot of time is spent cleaning it. We've harvested autogenous bone. If you've ever placed a membrane, a barrier membrane, you know this was not an easy case to treat. I really have to give the credit for the treatment for these cases to Marcel Camello and my son Mark. They did most of the work. But this is clinical regeneration. We reopened it. We made a mistake of being very excited when we saw the result, and then she didn't want us to take the tooth anymore. This is the radiographic, and this is, finally we got the tooth. Well, her automobile fell apart, and she's a single mom, and she needed a car to get her son to school and to work, and we traded a used car for a tooth. You do what you got to do. But this is a procedure that took 2.5 to 3 hours to do because of harvesting bone and what we were doing. So we needed a better way and a quicker way, and one that we could live with the third parties. So here is a similar situation with a class 2 FERCA. And we take the histology, and we can see that everything above the green line is new, and we have periodontal regeneration. This is the first time this was ever published, anybody ever published periodontal regeneration for human histology in a class 2 FERCA. Sometimes the decision's easy. This person is in the office because she hates the way she looks. The upper left quadrant has a bicuspid that's ridiculous. It's had apicoectomy. She had had a root removed from the molar. And looking at this, my decision was it's ridiculous to build new to these teeth. Let's leave the molar and we'll put a crown on it, but let's replace the bicuspid, which would require 2 posts and cores with 2 implants. Easy decision. Excellent office. Everything is first made in white wax and tried in, and eventually ceramics, and great result. Easy decision. A visitor to my office last year shared this case with me and said, I want to show you what was done where I practiced. And I'm only showing this to show you that implants are not 100% successful. But we can do an awful lot for a patient. This is somebody in our files from 1951, and this is how he was in 1970, and then he was restored with natural teeth without implants. It works. I have one last 4 or 5 slides, okay? The question is, can periodontally compromised patients survive with dental implants? So this is 1991. The man is 36 or 37 years old. Many of his teeth were removed and replaced with implants, and as we get to 2006, the maxilla is complete implants, and if you look at the mandibular molar, he continues to fail in the mandible. So we replaced the mandibular bicuspids and mandibular molar, and 20 years later, he's had almost no damage to the implants. What I've tried to do is to take what could easily be a full-day conversation and condense it into 30 minutes. I hope it's been useful to you and gives you some thoughts to take back to your practices and make value of. Thank you.